Well, hello everyone, and thank you so much for joining us tonight for our webinar, Latest Advances in Bladder Cancer Treatment. I'm Teresa Blondin, the National Volunteer and Program Manager here at Bladder Cancer Canada, and we're thrilled to have you join us as we explore advancements in bladder cancer care and what they mean for patients, caregivers, and healthcare professionals. Bladder cancer treatment is evolving rapidly and as of late has had some major advancements with the newly approved treatment of Enfortumab Vedotin plus Pembrolizumab, or simply known as EV-Pembro. During this session, we'll provide some key information on the individual drugs, the data that led to the combined drug approval, and more about the combined treatment. We'll also hear from someone who has been treated with EV-Pembro before we jump into a Q&A. And please remember that webinars contain content intended for the sole purpose of information sharing and should not be considered medical advice. Always talk to your doctor and/or urologist about what is best for you. So now I'm honored to introduce our presenters for the evening. First, we have Dr. Alimohamed. She's a medical oncologist at the Tom Baker Cancer Center in Calgary, Alberta, as well as a clinical associate professor in the Department of Medicine at the University of Calgary. She's involved in all levels of undergraduate, postgraduate, and continuing medical education, and is the program director for the Medical Oncology Training Program in Calgary. Dr. Alimohamed is actively involved in clinical trials in genitourinary and breast malignancies with specific research interests in genitourinary oncology. She's working to improve outcomes for patients with bladder cancer through real-world evidence collection, patient care pathways, and biomarker evaluation. She also serves on the Medical Advisory Board for Bladder Cancer Canada. Thank you for being here. And we're also honored to have Dr. Eigl here with us today. Dr. Eigl is a medical oncologist at the BC Cancer Agency. He graduated from McMaster University and completed his oncology training and genitourinary fellowship at BC Cancer Agency before moving to Calgary, where he served as head of genitourinary tumor research group, medical director of the clinical trials unit, and director of the Alberta Clinical Cancer Research Unit. Currently, as the Provincial Director of Systemic Therapy Clinical Trials, Dr. Eigl works to increase the impact and activity of clinical trials for cancer patients in BC. Dr. Eigl's research interests include bladder and prostate cancers, and in the clinic he sees patients with genitourinary cancers, including prostate, bladder, kidney, and testicular cancer. And we're also honored to have a spokesperson for BCC, Serge. Serge is in his mid-40s, married with 2 adult children, a grandfather of an 18-month boy, and a second on the way. So congrats, Serge. He enjoys golf, football, and time with his growing family. Serge was diagnosed with bladder cancer in February of 2022, and the cancer returned in April of 2024, and he was treated with EV-Pembro. So thank you all for being here, and I will pass it to Dr. Alimohamed to kick things off.
Thank you so much, Teresa, for that introduction, and welcome everyone. It's nice to see so many people from across the country online here. So over the next, hour and a bit, we'll take you through some of the latest advances in bladder cancer treatment. We'll discuss sort of the new treatments that have come up over the last several years for bladder cancer, and then we'll talk about the new combination of Enfortumab Vedotin and Pembrolizumab. I'll then hand it over to Dr. Eigl, who will talk about how the treatment's given, potential side effects, and how we can mitigate and manage them. And then Serge will give us his patient perspective as well. To review a little bit about bladder cancer, we know that it is a fairly common cancer. It's about the 5th most common cancer overall, and it is, traditionally thought of as the most expensive cancer to treat, usually because the majority of patients are diagnosed with non-muscle invasive bladder cancer, but that tends to recur. So patients usually have to be put on a surveillance protocol for a long time, usually the rest of their life, if they have sort of high-grade disease. In the past, this cancer has been more common in males with a median age of diagnosis of around 70. And in North America, smoking is the biggest risk factor, with, current smokers having about a 4 times risk compared to the general population of developing this cancer. The reason that we're here today is to sort of highlight some of the improvements. Historically, for a long time, patients with advanced bladder cancer had poor outcomes. And when I talk about advanced bladder cancer, I mean those cancers that are diagnosed kind of later on in stage 2, 3, or 4. The vast majority of bladder cancer is non-muscle invasive, so 70% of bladder cancers are diagnosed in the non-muscle invasive stages. However, 30% are diagnosed as muscle invasive or metastatic bladder cancer. And those cancers behave a bit differently. So even those stage 2 muscle invasive bladder cancers, they have a high likelihood to come back despite optimal treatment. Historically, patients with stage 4 bladder cancer, only 25% of them or less lived beyond 5 years. When we talk about metastatic disease, we're talking about cancer that has spread throughout the body. And how do those cancer cells get there? They usually travel through the lymphatic system and the blood vessels. So we think of it as cancer cells that have left the bladder, left the urothelial tract, and are traveling throughout the body. It takes about 1 billion cancer cells to show up as a centimeter on a scan. So there's lots of tiny cancer cells that can be traveling throughout the body in stage 4 or metastatic disease. So when we think about treatment, we need treatment that travels everywhere as well, and we call that systemic therapy or treatment that goes everywhere. Some of the most common sites of metastatic disease for bladder cancer include bones or other parts of bones in the pelvis or other parts of the body, lymph nodes in the pelvis or abdomen, the liver, and the lungs. This timeline sort of shows us that for the past several decades, so from the 1970s until very recently, where we're using chemotherapy. So cisplatin is a very effective chemotherapy drug, and our protocols for treatment hadn't really changed until the last few years. So it wasn't until the late sort of 2016, 2017, where immunotherapy was first starting to be used, and I'll take you through some of these developments. So prior to these new developments with immunotherapy and antibody drug conjugates, we used chemotherapy to try to help control the disease. So if a patient had metastatic urothelial cancer, you would get platinum-based chemotherapy, cisplatin or carboplatin with gemcitabine. We used to give 4 to 6 cycles, and then patients were monitored. So once the chemo was done, then patients would be monitored. Unfortunately, the median survival, which means the average time that patients lived from the time of diagnosis, despite treatment, was only about 12 to 16 months. Along with chemotherapy came many side effects like nausea, fatigue, neuropathy, low blood counts. There were many side effects that impacted quality of life. And although these cancers responded, so we had response rates of 40 to 50%. That means in 40 to 60% of patients, we could see that the cancer lesions on scans were shrinking, their symptoms would improve. However, oftentimes those responses were short-lived. So we didn't see a lot of durable responses, so patients continuing to benefit for a long time. Usually the cancer would respond, it would listen, those lesions would shrink, but then in a few short months, they would grow back. So our old treatment algorithm, when a patient came to us with metastatic disease, was we would assess them and talk about chemotherapy, decide if they were eligible for chemotherapy. And if they were, they would get 4 to 6 cycles of chemotherapy. And then they would be put on a plan where we monitored the cancer with scans, monitored the patient. And if things progressed, then we would use different chemotherapy like docetaxel or paclitaxel. Immune checkpoint inhibitors were kind of the first breakthrough in a long time. So checkpoint inhibitors are molecules, all of the ones that we have right now and that we're using in clinical practice are given intravenously. These are molecules that wake up the body's immune system to recognize the cancer and act out against it. So if you see here in this left diagram, you have a tumor cell, and the T cell is part of the immune system. This PD-L1 and PD-1 complex, PD-L1 binds to PD-1 and inhibits this immune cell from killing the tumor cell. But with these new treatments, checkpoint inhibitors, you block PD-L1 or PD-1, which then allows the T cell to kill the tumor cell. So some of the medications that we're using that are in this category in bladder cancer include Pembrolizumab, include Avelumab, and include Avelumab. The first breakthrough came with Pembrolizumab as second-line therapy for advanced urothelial cancer. And when we talk about second-line therapy, these are the patients who previously got chemotherapy, that 4 to 6 cycles, and then they were monitored. And then if the cancer grew back, they would receive Pembrolizumab. This large study was the Keynote 045 study, and it randomized patients to receive Pembrolizumab, this new immunotherapy, or the older chemotherapy drugs that we used to have. So the results from this study showed that immunotherapy significantly improved overall survival. So in this second line setting with chemotherapy, the average survival was around 7 months with chemotherapy, but with immunotherapy, that increased to 10.1 months. What was more exciting than that 3-month average difference, though, was that some patients were responding for a long time. So we were finally starting to see what we call durable responses. So patients would receive the treatment and it would seem to work for a long time, unlike chemotherapy. With new treatments come new side effects. You can see on this chart here, the dark green bars are the immunotherapy related side effects. So there's new things that immunotherapy can do. We're waking up the immune system, so we expect there to be some degree of side effects like pruritus, which is itchiness or a rash that can happen as the immune system reacts against the skin. Some people get tired. There's a little bit of nausea, less than with traditional chemotherapy. And really, now that we're more familiar with immunotherapy, the way that I tell my patients about this is that anything in the body that can get inflamed can get inflamed. And so if you have diarrhea, we need to think about, is this related to the immune system waking up? And there's certain things that we would do to help sort that out. But overall, if we compare chemotherapy to immunotherapy, the chemotherapy side effects tend to be more impactful to the patient's quality of life, like fatigue, like nausea, developing those low blood counts, etc. Once we learned about immunotherapy, further studies were done to try to then improve on outcomes even further. So the next breakthrough that came about was maintenance immunotherapy with avelumab. This was the Javelin Bladder 100 study, and this was initially presented in the year 2000. So this protocol really looked at patients who received chemotherapy, and then instead of waiting until the cancer grew again or progressed, patients were put on maintenance immunotherapy right after they had finished those 4 to 6 cycles of chemotherapy, right after they'd sort of recovered from the side effects. And these are in patients who had a response to chemo. So most patients will have a response or stable disease, and then they would be put on immunotherapy. And in this large study, it was compared to waiting until the cancer grew again. And this was a big breakthrough. As you can see here, the overall survival, so the dark blue line here, was significantly improved in favor of maintenance immunotherapy with avelumab. And the median overall survival from the start of that maintenance immunotherapy was about 21 months. These are for patients who have not progressed on chemotherapy, and that immunotherapy avelumab is usually started about 4 to 10 weeks after the last dose of chemo. This treatment is given sort of once every 2 weeks. So that sort of led us to this algorithm here. So now patients are getting chemotherapy. If they have a good response, the chemo has worked, you're feeling better, then after the chemo's done, patients would be put on immunotherapy with avelumab. If the chemo didn't work, then we would give you pembrolizumab immunotherapy. So then that brings us into the next category of medications which have recently been developed. Antibody drug conjugates are now being used in many cancer sites. In bladder cancer, the medication that we've been using for a few years now on its own is called Enfortumab Vedotin. An antibody drug conjugate is like targeted drug delivery. We have sort of a chemotherapy compound that is bound to an antibody. That antibody gets attracted to the cancer cells, and the chemotherapy is dumped or released into the cancer cells. So you get this targeted drug delivery, this local tumor cell kill. Enfortumab Vedotin, this antibody drug conjugate, it binds to Nectin-4, and we know that Nectin-4 is overexpressed on most urothelial cancer cells. In the early days of investigating this drug, everybody was being tested for Nectin-4 to see who would be eligible. However, we quickly learned that most bladder cancers have a high expression of Nectin-4. And so we no longer need to test for the expression of Nectin-4. We just assume that everybody should have some benefit from it. So this molecule, it contains MMAE, which is the cytotoxic drug, the chemotherapy drug. This whole complex is internalized. The MMAE is released into the cancer cell, which causes that cell to die. This was initially studied in advanced urothelial carcinoma in patients who had received chemotherapy and received immunotherapy. Enfortumab Vedotin was compared to the older sort of chemotherapy drugs that we have. So we call this sort of the third line setting, or post-chemo, post-immunotherapy setting. And as you can see here, it did show a benefit. So this drug was shown to be effective in patients who had already been treated with 2 different lines of treatment. The median overall survival now was improving even more. So the overall survival from the time of starting this medication was around 13 months. And this is Enfortumab Vedotin on its own. It's intravenous treatment. Also, what was more exciting is that we're now seeing a lot of patients responding. So with chemotherapy in this setting, less than 20% of patients had a response, which means their tumors shrunk. But with Enfortumab Vedotin, that number was around 40% of patients were benefiting and responding to this treatment. With a new medication also comes new toxicities again. So there are special adverse events or side effects that are related to this antibody drug conjugate, notably a rash, neuropathy, which is an impact on the nerves, as well as an elevated blood sugar. And Dr. Eigl will talk more about these. Another targeted therapy that has been developed for use in bladder cancer is Erdafitinib. And Erdafitinib is an oral tablet. It's an oral targeted treatment. Approximately 20% of advanced bladder cancer patients have alterations in FGFR. In patients who have an upper tract disease, so a cancer that starts in the ureter or the bottom of the kidneys, that number is a little bit higher. If this protein is altered, that can serve as an on signal to those cancer cells. So it can drive those cancer cells to grow and divide. And Erdafitinib is a pan-FGFR tyrosine kinase inhibitor. So this complicated diagram here is just showing us this signaling pathway. So if this FGFR is altered or mutated, it can serve as an on switch for that cancer cell. And Erdafitinib is like an off switch. It's an inhibitor to this. So this is only for patients who have an alteration in this target. So this was also studied in patients who had received chemotherapy and immunotherapy. So patients who had received chemotherapy, immunotherapy, Erdafitinib was again compared to older docetaxel or paclitaxel chemotherapy. And as you can see here, next slide, is that it also improved how long patients were living. So it's better than our older drugs of choice that we had at the time. And again, a significant number of patients, about 46% of patients, were responding to this treatment, again, if they had that alteration. So that sort of led us to this era where we had multiple lines of treatment. So patients would get chemotherapy if they were eligible, then they would get some form of immunotherapy, and then most patients would get Enfortumab Vedotin or Erdafitinib if they were eligible. If they had an FGFR alteration, they could get sort of all 4 of those lines of treatment. For Erdafitinib, a caveat is that the testing is currently not standard in the whole country. So lots of provinces are doing testing in different ways, like as part of clinical trials. For very recently, over the last year, we've all been very excited to treat bladder cancer because a new regimen has shown a significant improvement compared to this old standard that I showed you. So we're going to go beyond chemotherapy in the first line setting. So I'll take you now through the data which highlights the efficacy of this combination, Enfortumab Vedotin and Pembrolizumab, in untreated urothelial cancer. So this is the EV-302 clinical trial. And the results were first presented at an annual meeting last fall. And now this regimen has been Health Canada approved. It is available to patients across the country, although in in varying ways. So there is a patient support program, and we're sort of in this window where it is Health Canada approved, but now it can take another 6 to 12 months before it actually gets on all the provincial formularies and delivered in the hospital setting. So this study was designed to look at patients with metastatic urothelial cancer who have just been diagnosed and not received any previous treatment for metastatic disease. Patients must have been eligible to receive chemotherapy and immunotherapy, and they must have had a reasonably good performance status, which means that they're well enough to tolerate these treatments. This was a study that was performed around the world. So patients were accrued from around the world, and it enrolled over 880 patients. Because at the time chemotherapy was our standard of care, patients were randomized to that standard of care, which was chemotherapy, cisplatin or carboplatin for up to 6 cycles, or this novel combination of Enfortumab Vedotin plus Pembrolizumab. And the treatment with Enfortumab Vedotin would have been no maximum number of cycles and up to a total of 2 years of Pembrolizumab. Treatments were obviously stopped if there were side effects that were unmanageable or if the disease had progressed despite treatment. As you can see here, this chart shows us progression-free survival. So this means from the time that we start treatment, how long is it before patients progress? So before their cancer gets worse on a scan or clinically. And you can see here with chemotherapy, that average progression-free survival was around 6 months. With this new combination of Enfortumab Vedotin and Pembrolizumab given together, that median progression-free survival was doubled around 12.5 months. So in this world, these graphs are really exciting for us to see. That's a big difference. Those curves are really far apart. And similarly, overall survival was significantly improved with this novel combination. So with chemotherapy, the median overall survival, so the average time that patients were living on study if they got chemotherapy was around 16 months. With EV plus Pembro, that median overall survival was 31.5 months. That risk of death was reduced by about 53%. That's what those numbers sort of translate to in patients who received EV plus Pembro compared to chemotherapy. We also look at pre-specified subgroups. So did it matter if the patient was, younger than 65 or older? Did it matter if they were male or female? If the cancer started in the upper tract or the bladder? Did it matter if there were liver metastases? Did it matter if a patient was eligible for cisplatin or not? And as you can see here, that survival benefit was seen in all subgroups. So that was consistent with the overall population. So none of those factors seemed to matter. Everybody seemed to benefit from Enfortumab Vedotin plus Pembrolizumab over chemotherapy. We've talked a little bit about response rates, and as you can see here with this new combination, the response rate was 68%, and that includes patients who had what we call a complete response. A complete response is when everything on imaging now becomes so small that it's less than a centimeter, or it disappears and there's no new spots that show up. So with Enfortumab Vedotin plus Pembrolizumab, 29% of patients had what we call a complete response. So this data was very encouraging and very exciting to be able to offer to patients. So this really was the first regimen to surpass platinum-based chemotherapy in the first-line setting to treat metastatic urothelial carcinoma. As I've shown you, there's significant improvements compared to chemotherapy, and it is what we think is the new standard of care for most patients. There's a caveat to that in that some patients are not eligible for immunotherapy. So it's important to talk to your doctor about your options and about this option if it's available to you. And now I'll hand it over to Dr. Eigl, who will take us through some of the very important parts about toxicity management. I think we've been through this. Right, one more slide on patient advocacy matters, and that it's really important. I'm happy to see so many patients and caregivers on the line today because patient advocacy and education is really important. Enrolling on clinical trials, learning what that means is important. We know that when the data was presented about this large study, patients advocated to regulatory bodies to ensure that Health Canada looked at this protocol quickly. Health Canada approved the regimen in August, and by September, a patient support program had opened, which means that patients were able to access this in most parts of the country. And now funding discussions are ongoing. And we're waiting for those, and then for all the provinces to approve it before this can be delivered in all of our cancer centers across the country. So with that, I'll hand it over to Dr. Eigl. Thank you.
Great. Thank you, Dr. Alimohamed, for that really great presentation and overview of how much the standard of care for bladder cancer management has changed over the decades. When I finished my training and started treating bladder cancer around 2005, the median survival of a patient sitting in front of me with metastatic bladder cancer would have been 8 to 12 months, and very, very few patients lived to 5 years. And now we are at incremental steps forward, and one big jump recently that we're talking about medians of 3 years and increasingly patients being cured of this disease. So I'm very excited to be treating bladder cancer today. Those are my disclosures. I'm just to speak a little bit about the logistics of the treatment. In terms of what you see in the clinic of the treatment, it's actually very similar to the standard chemotherapy treatments that we've been doing for decades. A patient would come into the infusion site, a nurse would start an IV, and if, for the sake of argument, you started treatment on a Monday, you would get the first two medications given, the Enfortumab Vedotin through an intravenous over about an hour, and the Pembrolizumab as well as an intravenous, and then you go home. You come back the next Monday and you just get the Enfortumab Vedotin drug on day 8, and it's what's called a cycle. So every 3 weeks it repeats. So you're getting 2 treatment days, day 1 and day 8, every 3 weeks. And just so you've seen the dosing, the Enfortumab Vedotin is dosed at 1.25 milligrams per kilogram up to that maximum dose. As we'll talk, we do adjust the dosing depending on side effects. Whereas with pembrolizumab, the immunotherapy, it really is a treatment that either the immune system is on or off. The dose changes wouldn't really make a difference. And so either we are giving the treatment, or if there are side effects or reasons to stop, we hold or discontinue the treatment. This is just a schema of how the dose reductions of Enfortumab Vedotin are given. So we will go down stepwise depending on side effects and the need to reduce the dosing. So what about the toxicities? I think when we talk about these treatments, which are so exciting, and the combination of Enfortumab, which you saw was something we used to use in the third line setting after chemotherapy and immunotherapy, combining it with immunotherapy and giving it up front, really capitalizes on the synergies of these treatments. It's a 1 + 1 = 4 sort of combination where the two drugs work together to give more activity against the cancer. Unfortunately, there's also a lot that we have to learn about the side effects and the toxicity, and there's potentially synergy there as well. So with this combination, we really have to be aware of these toxicities, and I'll go through them in some detail now. So skin toxicities, nerve toxicities, so neuropathy that Dr. Alimohamed mentioned, some of the endocrine, your glandular toxicities, if you like, so high blood sugars, thyroid and adrenal issues, GI toxicity, and lung toxicity, pneumonitis, as well as sometimes eye toxicity. And I'll go through sort of the highlights of these. I'm not going to go into a lot of detail on everything. When we look at medications like Enfortumab Vedotin, we sometimes think about this is an antibody that's been designed to stick to bladder cancer, and it sticks to a protein on the cancer surface. And in the case of Enfortumab Vedotin, EV, it is Nectin-4 is a protein that's there. The antibody sticks to it, and then it gets taken into the cell, and it releases the poison and kills the cell. The poison is MMAE. And so when we think about the side effects, we often think about what is the target, and is that target the nectin expressed somewhere else in the body? And that's where some of the side effects, we call them on-target side effects, occur, because it's hitting that target where we don't want it to be hit, if you like. And what are some of the off-target side effects from the payload, from the poison itself? And so Nectin-4 is expressed in some normal tissues, the skin, especially the sweat glands and follicle area, and also in the upper GI tract, so your esophagus and your stomach. And that's where some of the side effects then come in from that. And just going through the two drugs, Enfortumab Vedotin and Pembrolizumab, the side effects, it's a big list of things here, but like on the right side, the immunotherapy, like Dr. Alimohamed said, if something can get inflamed, it will get inflamed. I won't belabor that. It's actually very low percentage risks of a lot of the side effects of the autoimmune side effects, but we, as the treating physicians, have to be aware of them all. Um, but the Enfortumab Vedotin is the one where there are side effects and they're related to how much you give and how long you give it for. And so that is where we really have to pay attention and make adjustments. And as I mentioned, so the GI tract and the skin are two of the major areas. Um, so let's talk about that. I've mentioned the on-target toxicity. The off-target toxicity is this MMAE, the payload, the poison. It can irritate the nerves, and that's where the neurotoxicity comes from. It can irritate the lining, the sclera of your eyes, and so that can sometimes cause dry eyes and side effects like this, and can also lead to sometimes irritation of the lungs, more rarely, but also high blood sugars. And when we look at the percentage of these risks, this is from that EV302, the big landmark study that Dr. Alimohamed mentioned. We can see what the percentages are, and we grade these toxicities. So it goes actually from 1 to 5, where 1 is just a little bit of nuisance toxicity, and 5 would mean you've unfortunately died from the toxicity. So we hopefully never see that. But grade 3 and 4 means grade 3 means you're actually intervening with potentially drug therapies or other treatments for the side effect. And grade 4 often is we have to hospitalize you or you have a life-threatening toxicity. And so if we look at any grade toxicity, these numbers are often very high because in clinical trials, we write down everything. If you have a runny nose, we're going to write down runny nose as a side effect, even if it's not a significant side effect, even if it's not related to the drug necessarily. But where we really focus in on is these grade 3 or higher toxicities, which are potentially significant for your quality of life. And so 15% of patients on the combination had some skin reactions that required intervention. Now, that could be anything from a steroid cream to other interventions or stopping the treatment. Peripheral neuropathy is, again, numbness in your fingers and toes, tingling. Sometimes it can be a motor neuropathy where you have, weakness, trouble picking things up. And so that was more common. And if we look at all grade there, 63%, I would argue all grade neuropathy can be significant for patients, of course, because if you have a bit of numbness, even though it may not be a grade 3 event, it's still significant. So we have to be aware of that. And then the eye disorders, you can see the dry eye, eye irritation, 21% of patients, but none of it was really very significant of grade 3 or higher. And the high blood sugar, hyperglycemia, again, I'll speak a bit more to that later, but that is a toxicity to be aware of. Some of the we as the physicians treating this are actually constantly learning right now because these are new treatments and we have a lot to learn as we go. And we've learned that some of the side effects come at different times during the treatment, and that helps us sometimes figure out, is this the EV that's causing the side effect? Is it the pembrolizumab causing the side effect? Is it unrelated to the treatment altogether? And so if the blood sugars go up, it's usually early on, whereas the neuropathy side effect is something, the numbness usually accumulates over time, and we see that coming along, and we have to make dose adjustments or changes to manage that. But these are all, rules of thumb really that are helping us to manage the disease and the side effects of treatment, as well as trying to sort of sort out where to look out for. But these things can happen anywhere. I don't know that I have to belabor the blood testing that we have to do for this talk, but again, you'll have a lot of blood work done while you're getting treated with these medications because we have to monitor your blood sugars and your liver function tests to make sure your liver isn't being irritated, and other blood tests for other abnormalities that we pick up along the way. Quite often, or most of the time, we don't pick up abnormalities, but obviously we have to identify these early so we can intervene and make sure that your cancer is being managed properly. Um, in terms of when a physician is evaluating you, they would be looking at, do you have other conditions? Do you have diabetes, or do you already have nerve conditions, neuropathy, or do you have side effects from the prior treatments you might have had for your cancer? And that all plays into the way we approach the treatment of this disease and the management of the side effects. And we have to work together. And I think the red point down here is patient and caregiver education regarding the signs and symptoms of toxicity is very important. If we are treating patients with this medication, I always talk to my patients about the main side effects to look out for, especially skin toxicity and neuropathy, because those can become bigger problems if they're not addressed early, and we want to see that improvement. Um, in terms of skin toxicity, again, as a physician, we would be evaluating, do you have prior risk factors? Do you have allergies? Do you have dry skin? Have you been on immunosuppression? Have you got skin that's been sunburned all your life? And those are factors that play into our decision making around how to manage and how to treat with this medication. And there are some general precautions. Any anti-cancer therapy is an insult to your skin, to be honest. And so we always talk about using protectants, using sunscreen, wearing long sleeves and hats, and these are all general precautions that we can all take when we're being treated with systemic therapies for cancer. Um, these are just some examples of some of the toxicities we see. First of all, this is looking at under a microscope, looking at your skin. So slide A here, you can see the dark stained cells are cells that have nectin on their surface. So that is what what EV goes after, the target that's expressed on the bladder cancer. But you can see here it's expressed in the skin as well. So if we have a homing missile that comes in and kills the cancer, it's unfortunately also going to attack the skin. And so, as you can see here, rashes are very common. They're often common in the folds of the skin where the sweat glands are. But the toxicity that we worry about the most is blistering, like you see on the foot in this slide. If there's blistering, that can be a very serious condition that needs to be treated as an emergency. And this is really why we do so much education with our patients around skin toxicity. The vast majority of patients have very little skin toxicity, and actually a little bit of skin toxicity, some itchiness or redness or a bit of a rash might be a good sign. There are some studies now that are showing that a bit of a rash might correlate with better outcomes on treatment. But what we're worried about is the big serious rashes, which occur in the vast minority of patients, but are issues that we have to deal with urgently. And so if patients call in with skin toxicity, the five big questions that we always ask is, do you have a fever? Is there any blistering of the skin? Do you have pain? Itchiness is okay, but pain is not something we want to see. Are mucous membranes involved, like your mouth or your vagina? Are there abnormal blood tests when we do them, like liver function test abnormalities? And these would be big warning signs that this is actually an emergency and we need to deal with this skin toxicity here and now. And so we do a lot of education around that. This is a bit of a busy slide, but it really speaks to the grading that I mentioned before. And we are worried, like I said, about grade 4, grade 3 and higher side effects. And you can see here for grade 1 and 2, we really don't have to intervene very much. You might use some antihistamines if there's an itch. You might use some topical steroid creams. But it's really when you get to grade 3, the more significantly limiting side effects that we talk about introducing oral medications like prednisone that we talk about decreasing the dosing along this dose reduction schema that I showed you earlier, and making other modifications to make sure that we don't run into trouble of these more serious and sometimes, to be honest, life-threatening skin toxicities if they do occur. And fortunately, again, these are very rare toxicities. This just underlines what I've really already said. The majority, 55%, can have any kind of skin toxicity, and that's okay. But it's the 10 to 15% that have more significant toxicity, and it's about 8% are very serious events that we really have to pay attention for and look out for. But again, this is a treatment that is so very effective, and these side effects are very manageable as long as we all work together, patients and caregivers, to identify problems early and deal with them early. So that is my main thing, is we start talking about skin assessments and do them on an ongoing basis very early on. In terms of the neurotoxicity, so the nerve damage that can occur, again, this is usually the peripheral nerves, so the ones that go to your hands and your feet. And what patients can complain of is some numbness, tingling, trouble with fine motor skills, potentially. There can be effect of the sense of where you are in space, so your balance can be affected. These are more cumulative toxicities. They are, again, from that MMAE payload, and can be quite common, 50 to 60%. If they're identified early and the medication is paused or dose reduced, we find that the numbness and tingling can get better, and we can manage this so that it isn't a significant nuisance or problem for patients. But if it is left unmanaged, the nerve damage can become more severe and more long-term and irreversible. So this is something, again, that patients and caregivers have to work together very closely to identify numbness or tingling or other nerve toxicities before they become significant limitations that could be irreversible. We monitor for other nerve issues, and as I said, evaluate regularly, assess the impact on daily living. So I might ask a patient, are you having any trouble buttoning your shirt or handwriting or picking up a coin, tying your shoelaces, any trouble, tripping on carpets, things like this. And just informing patients what to look out for and the fact that these things should be reported immediately. And then, if you remember, the pembrolizumab, the immunotherapy, can also attack any part of your body, including your nervous system. But the toxicities from pembrolizumab, thank goodness, are very rare, but are also potentially more serious and have to be thought about when we see numbness or weakness. And so autoimmune disorders like Guillain-Barré syndrome, myasthenia gravis, and so forth are toxicities that we are always aware of and looking for, but thankfully very rarely see. In terms of eye disorders, again, most of these are surface disorders of the eye and not major toxicities, and they usually are reversible with pausing the medication. Contact lens use can increase the risk of developing some of these, and dry eye. So we can recommend eye drops and making sure your eyes are well lubricated, and maybe avoiding prolonged contact lens use while you're on treatment. And again, these are usually reversible. In terms of general management, we work very closely with our specialists, as oncologists, with ophthalmologists in the case of eye toxicity, or all the other specialists for any of the other toxicities that occur, especially dermatology. And really, a lot of this might seem like common sense, but we have to make sure that patients and caregivers are educated on good hand hygiene, treating dry eyes with cool compresses or warm compresses, lubrication, artificial tears, and so on to manage this. And we will dose interrupt the enfortumab if there are toxicities such as these. In terms of hyperglycemia, so high blood sugars, Obviously, if patients have prior existing blood sugar issues, diabetes, or they have a high body mass index, or have ongoing medication use, such as steroids that can make your blood sugars go up, we have to be aware of all of those. And the symptoms we look out for: increased thirst, dry mouth, frequent urination, blurred vision, fatigue. These are all classic diabetes type of symptoms, and obviously we're always on the lookout for these. Um, the incidence of hyperglycemia or high blood sugar with this combination of treatment is actually not super high. Maybe 1 in 10 patients will have some blood sugar elevations, and we always monitor the blood sugars during treatment. Um, when EV is the cause, we don't actually know exactly how EV causes high blood sugars, but it is a reversible cause. So you stop the medication, you take the dose down, and the blood sugars usually drift down back into the normal range. Um, Pembrolizumab can, again, rarely 1.1% for all grades, and less than 1% for higher grade, but it can rarely cause the autoimmune disorder of diabetes, which is an autoimmune disorder. And so again, we just have to think about that as a possibility, but it is actually quite rare that we would see diabetes caused by this treatment, like true type 1 diabetes. I've already mentioned this, that we don't know what the cause of it is, and the grades. I don't think I need to go on too much with this, but again, this is just one of the many blood tests that we have to do while you're on treatment with this combination of therapy. And this really is just saying that we, again, work closely with patients to be aware if you have symptoms, if you're drinking more fluids, if you're going to the washroom more often, if you're feeling more fatigued. We have to think about high blood sugar as one of the potential causes for this. And certainly if your blood sugars are over 13.9, that is sort of the threshold where we say, okay, we have to hold this treatment and let things go back to normal before we can look at restarting the treatment. And we work with our endocrinologists very closely as well for this and other side effects. In terms of lung toxicity, this is actually relatively uncommon with EV Pembro, but we have to be aware of it. The pembrolizumab can cause lung inflammation through an autoimmune mechanism. And again, if patients have prior conditions, we have to be aware of those, and we have to make patients aware of the symptoms, which again is pretty self-explanatory. If you're short of breath, or if you have a cough, or you have chest pain, fever, those are things we have to be aware of. And f- finally, gastrointestinal toxicity. So pembrolizumab can cause an autoimmune inflammation of the bowel, which is called colitis. And pembrolizumab or enfortumab vedotin also can cause irritation of the bowels, so can cause diarrhea. And so we always have to be aware of making sure that you're well hydrated. If you get diarrhea, you should let your doctor know right away, or your healthcare team know right away, because we have to assess whether this is potentially, something you ate yesterday, or whether it's actually something more serious that we have to assess and manage more aggressively so it doesn't become a problem. And if you ever have blood in your stools, mucus in your stools, or fever associated with your diarrhea, that is something you urgently need to let your team know. So in conclusion, we have this amazing new treatment of EV Pembro. It really is a game changer and has moved the care of bladder cancer forward significantly. And those of us who treat bladder cancer, especially older guys like me who have been treating it for a long time, really are excited about having this option available and seeing patients who have been cured of the disease. But we have to be aware of the side effects and work together to manage those. There is now data to say starting at a full dose induces responses better, and 97% of patients have some shrinkage of their cancer with this treatment. So it's very effective. But don't be alarmed if your doctor says we have to lower your dose for side effects, because actually those responses are maintained in patients, often even if they have to stop the treatment with EV altogether. So it's exciting times indeed. And this is a very busy slide to say a lot of what Dr. Alimohamed has already said, so I won't belabor it, but really just we have a great new treatment. It's very effective. Early recognition of management of toxicities is critical, and patient education. But most of these can be managed, and by working together with your healthcare team, we will have better and better outcomes. So I'm going to pass it on to Serge now, who is going to tell us about his perspective from a patient's point of view.
Thank you, doctor. I've been receiving the treatment since late May. I believe I'm entering my 9th or 10th cycle. The symptoms, the first one the side effects that I felt was the dry eyes, which is managed pretty easily with some drops. And so there's a little bit of a list here, and I don't want to discourage people because most of them can be managed fairly easily. And the quality of life has surpassed my expectations going into this. So fatigue is also something that I had to learn how to manage. My hemoglobin gets low, my iron gets low. I'm able to function. I'm able to do many of the activities I did before. I just have to plan for rest periods and I sleep a bit more. But other than that, I was able to golf and walk the course 3 times a week this summer. So it's just adjusting a little bit as to allowing some times to rest. Neuropathy is I do have neuropathy in my fingers and toes. It seems to have stabilized, so I'm able to function, just require a little bit more patience sometimes. But itchy skin is something that I don't necessarily have spread out rashes, but I do have very itchy skin, so that's managed again with some creams. The nausea is not as intense as I in 2022. I did a cisplatin-based treatment, and I have to say the side effects are a lot less intense than it was back then. So a little bit of nausea, but again, they give you medication to deal with that. And because I'm diabetic, the high glucose has become a factor for me. However, again, working with the medical team, we've been able to get that back on track. So that's about. I know it's a little bit of a list of, but again, I don't want to discourage people. It's for me, it's been manageable, and it's allowed me to maintain a pretty good quality of life.
Well, thank you so much, Serge, Dr. Eigl and Dr. Alimohamed. This is a really exciting new treatment, and we're so grateful that you were all able to share that high level of detail with us. So now we'll open the floor to questions. You can put any question you have for the presenters in the chat, and I will read them out. Do you believe that this treatment will ever be considered for other stages of bladder cancer or just for advanced and metastatic cases?
Yeah, no, it's a great question, and with most new treatments that come along, if they look promising and have good data in the advanced setting, the next logical question is to ask, well, what about the earlier setting? And right now in the curative intent bladder cancer setting, our standard is some chemotherapy and maybe immunotherapy. And I think I saw one poster there saying they're on nivolumab right now, so that's in the curative sense. But this combination exactly has been tested already, being given before surgery for people with curative intent bladder cancer treatment. And that study we're all very excited about. We're just waiting for the results to come from that study. And it's a bit of a catch-22 when clinical trials go on, because the longer you have to wait for results, the better it sometimes is, because it means people are doing better and we're not seeing the endpoints, which are progression or death, right? So it's a good thing if we have to wait longer.
Okay, great. And you mentioned that it's approved by Health Canada. Will this treatment be covered in all provinces once it is approved at the provincial level?
Yes, that's exactly the hope, is that that's what we're waiting for, is for the provinces to fund it. So those funding negotiations sort of happen at a national level, first of all, and then it trickles down to the provinces. So that timeline from when something is approved by Health Canada to when patients can actually get it in the cancer center is sometimes, a long time, a year and a half, sometimes longer. So we're in that window right now, and the companies have joined together to provide a patient support program, which means that patients are not needing to pay for the treatment right now, which is great. There are some places in the country where the infusions can't be given though currently, so that is one caveat. But I do think that the program is up and running in most major cities.
Okay, and so there is a possibility that it could get covered in Alberta first and then later Ontario, something like that.
I anticipate that there might be kind of a little bit of timeline difference between the provinces, but there shouldn't be kind of more than a few months difference.
Okay.
And in the meantime, the patient support program continues to support patients until the provinces pay for it.
Question from the chat. What is the current state of identifying cancer markers for more targeted treatment?
So the evolution of research in bladder cancer has sort of really exploded now with all these new treatments coming along when all we had was old-fashioned chemotherapy for 40 years. And so markers are being identified all the time. There's a lot of research going on, actually in Canada and in BC, in circulating tumor DNA, which is a marker of, is there cancer in the body, and looking at what the DNA of your cancer shows. But even more simple markers, like some people might have heard of HER2 before, which historically we think of with breast cancer because we have treatments for HER2 positive breast cancers. We've always known that HER2 is, for example, expressed in a lot of bladder cancers, but the treatments that we had didn't really work. But now there are newer treatments targeting HER2 that look like they might work very well in bladder cancer. And so, although we don't have the perfect biomarker for anything in bladder cancer right now, there's a lot of exciting research going on that I think will give us sort of a way to tailor the approach of treatment and maybe give less treatment to some people who don't need it and targeted treatment to others who might respond to a specific treatment. So there's a lot going on, but nothing that's sort of really mainstream right now.
Okay. And a question about the Sunrise study with targeted TAR 200.
Yeah, that's a really good question. So that study, it's a neat idea looking at a new way of delivering medication into the bladder. So the Sunrise studies use this pretzel molecule with medication on the pretzel that's delivered into the bladder, and that's kind of put into the bladder by the urologist. So that sometimes in combination with immunotherapy, it's been studied in muscle invasive bladder cancer. And right now that we have phase 2 data, and usually we need sort of a phase 3 study before things are approved here. And that's currently in muscle invasive disease. So a different disease setting than what we're using Enfortumab Vedotin and Pembrolizumab for. But very good question. It sort of highlights all the new treatments that are coming down the pipeline and being investigated.
There's a lot of treatments like this of giving treatments inside the bladder, whether it's a TAR 200 device or there are viruses and other drug therapies that are being put into the bladder in patients who have localized either muscle invasive or non-muscle invasive bladder cancer. And I think a lot of those hold promise. But this is a systemic disease we're talking about today, where those treatments aren't going to do anything for all the cells that have gotten away from the bladder. So, yeah.
Okay, we're at 8, so I'll just do one more question. There's 2 that kind of relate. Basically, how can patients who are receiving conventional treatments switch to the combo treatment, and where is this treatment currently being offered? Basically, how can people get on it? Is there a possibility for new patients to enroll in that?
In terms of that EV302 study you saw was a study comparing chemotherapy to EV Pembro in patients who had not had prior treatment. And so patients who have had prior treatment are not eligible for that study, and so therefore are not considered eligible for this treatment. As bad as that sounds right now, it doesn't make sense from the point of view of sitting there as a patient who's getting treatment with cisgem or whatever the chemotherapy and durvalumab. It can't be done because the data isn't there to support switching over to EV Pembro now. What I can say is for somebody who has had a good response or stable disease to chemotherapy and is getting avelumab maintenance, if we look at the median survival for that population, it's actually very good as well, and comparable to the EV302 data, but that's a different population of people. So if you're on avelumab now, that's a good thing.
Okay.
Yeah, and then if things change on avelumab, so if your cancer progresses on avelumab, then you would be eligible for EV alone.
Okay, perfect. Thank you again, Dr. Alimohamed, Dr. Eigl, and Serge for sharing this vital information about bladder cancer with our community. We're truly grateful. And thank you to everyone who attended, and I hope you have a great night.